Today we'll be covering the topics regarding osteosarcoma. As you all might have known that osteosarcoma is actually a very wide topic. There are loads of its subtypes, and so the discussion regarding this will be divided into several videos. The first I would like to let you guys know is that there are many types of osteosarcoma and various literature has divided them in several manners, but I find this classification to be one of the easiest one to memorize. And basically osteosarcoma can be divided into those with central osteosarcoma, teleangiectatic, surface parosteal, periosteal, high surface grade osteosarcoma of the jaw, and also even the subtypes of the secondary ones caused or as seen in the Paget disease. Well, even though there are loads of osteosarcoma, I feel that there are certain types that needs to be known by an orthopedic surgeon. That includes the classic osteosarcoma that is commonly seen, those that are known as the telangiectatic type, and also the parosteal or periosteal type. And so in today's video, I will cover about the classic type of osteosarcoma. Well, before we move on to that, I should let you guys see these indicators of poor prognosis, because generally in most osteosarcoma types, the prognostic factors are the same. And so the poor prognosis can be seen in these certain population of patient, the ones with high expression of alkaline phosphatase or high expression of lactate dehydrogenase. There's also in certain subtypes of patient who does not have anti-shock protein 90 antibodies formation after chemo, and those population of patient who has a poor chemo response that shows less than 90% of necrosis rate. And these are the indicators of poor prognosis in patients suffering osteosarcoma. Well, basically osteosarcoma is a spindle cell neoplasm that produces osteoid. Spindle is actually the shape of the cells that resembles a spindle, and osteoid is actually sort of like bone matrix. So in histopathologic examination of patients with osteosarcoma, you can always see seams of osteoid matrix there. The color is lightly pink, and it's like a huge bland pink that has scattered cells all around it. We'll take a look at it later on the pathological slides. And these are the chemo regimen that is widely used, and one of the three most common drugs that I use are doxorubicin, cisplatin, and methotrexate, and each of them also have their own side effects, and these are frequently asked usually in exams, which include doxorubicin with its cardiac toxicity, cisplatin with its neurotoxicity, and also methotrexate with its myelosuppression effects. Well, I've mentioned before that when people have poor chemo response, then it generally means that they have poor prognosis, and usually chemo response in osteosarcoma can be graded based on this Hufos grading system. And in this Hufos grading system scheme, usually patient underwent chemotherapy before the operation, and then following the operation, usually the samples of the tissue that is obtained during surgery is evaluated for their necrosis rate. And if there is only little to no evidence of necrosis, then we say it is a Hufos 1, and so on until the patient can be graded into Hufos 4, which shows that there is a 100% necrosis. Most papers would say that Hufos grade 1 or grade 2 patient with necrosis rate under 90 would be considered as those that have poor prognosis. And so after knowing all that, we will start today's discussion regarding the most commonly found type, which is the intramedullary osteosarcoma. Well, basically because it is an osteosarcoma, it's coming from the bone, and it is a primary sarcoma of the bone with age population most commonly found in children and young adults. Usually you could see it their peak incidence would be at the second decade, with the site that is most commonly found would be the distal femur, proximal tibia, but also all other bones such as proximal humerus, femur, and pelvis, although this is quite rare. Now, for the definition itself, we would say that osteosarcoma is a high-grade intramedullary osteosarcoma, also known as a classic osteosarcoma. These are just the other names that you should be familiar with. Well, for the etiology itself, tumor is usually related with the anti-tumor factors of our body. And so if there is some tumor suppressor gene, such as the retinoblastoma gene here, RB gene, that is suppressed, has abnormalities, then it's not normal to say that our body will have tendency to grow tumor. But sometimes the risk for this type of tumor is also found in other types of syndromes, such as the Rothman-Thompson syndrome, in which patient has this characteristic appearance with loads of facial rest. They are sun sensitive. There could also be loss of eyelashes, eyebrows, and hair loss. And these sorts of patients are also associated with other conditions such as cataracts, and they may have other type of malignancy besides osteosarcoma. And we all know about the P53, which is associated with the tumor. And so the classification, what I mean by classification here is that usually the patient, when found, is at Anneking stage 2B. For those of you who haven't know or familiar with the terms of the Anneking classification of sarcoma, then you should check out my oncology basics video, especially the part 2, where tumor staging and classification is discussed. So for the classification itself, you need to know that the tumor usually is found in stage 2B, and the tumor has a tendency to penetrate early to form soft tissue mass. And since this is a bone tumor, it means that the lesion has outgrown the bone and invade the surrounding soft tissue. Now, for the diagnosis itself, you know that a good diagnosis starts with a good history taking, and usually the patient shall come with these factors, which is pain, swelling, and sometimes fever. But you need to know that the fever can be caused by loads of things, which is such as increased inflammatory rate, could be also caused by their malnutrition, their dehydration, because these patients are generally found in a very bad condition. They have decreased appetite, and so they would refuse intake. And physical finding would reveal palpable mass, and usually in additional examination, the results are quite specific because this is basically a bone-forming tumor. You would basically see a blastic lesion, which means that the image should appear white on plain radiograph because of all those bones and all those calcifications that occur there. And sometimes you could also see periosteal reactions such as sunburst reaction or hair on end or Codman's triangle or soft tissue mass. Well, these periosteal reactions are generally seen in most malignant tumor because it is a form of defense that the body is doing to contain the tumor, and it can also be a clue for us that something wrong is occurring inside the bone, and so the periosteum is reacting towards it. So MRI is generally used to determine the soft tissue involvement, and especially you use it to determine the neuromuscular involvement or skip metastasis. As you can see here, if you find a skip metastasis inside the bone in which the tumor is situated in, you would generally classify it into a stage 3 according to the revised Anneking classification. And you could also use MRI to determine the neuromuscular involvement, as discussed in my previous oncologic basics video regarding limb salvage. That is the part 3 video. These MRIs are usually used to determine how the neurovascular status is, because one of the criteria to do a limb salvage surgery is that if the vascular bundle itself, sorry, I'm going to correct this, it should be neurovascular. If the neurovascular bundle is clear, then definitely the patient is he has fulfilled one of the criteria to underwent the limb salvage surgery. Next would be bone scan, which would usually appear very hot. CT scans are usually useful to screen for pulmonary metastasis because this tumor, especially the osteosarcoma, has a high tendency to go towards the pulmonary region and metastasize there. And multiple metastasis is also one of the contraindications to do a salvage surgery because the tumor has spread all over. But solitary metastasis over at the lung can sometimes still be treated with a lobectomy surgery. And for the labs, usually you could see an elevated ALP, although other lab measures can also be done, such as LDH. And then histology. Usually the histology depends on the subtypes. Some has lacy osteoid, some has significant atypia, but you need to know that the basic findings of all malignant tumor are the same. Usually they have different shapes of cell nuclei, or we call it atypia of the nuclei. And also there shall be different ratio or amount of cytoplasm that goes around them. Usually if the nucleus is bigger and the cytoplasm is getting smaller, or let's say it's a high nuclear to cytoplasm ratio, then it is also a bad sign. The next thing you could do is, if you see any giant cells, which means that there is a cell with loads of nucleus inside it, then it is also an indicator that this is one of the subtypes of the osteosarcoma. Well, next we are going to move on about the management program. As you can see here that I have placed in operative as the main management program, mainly because most osteosarcoma treatment will need operation, and usually it could be a multi-agent chemo along with limb salvage resection. And be sure to check out my previous videos regarding the basics, because limb salvage can usually only be done if the rate of clearance of the tumor after the tumor resection is equal to amputation, and the remaining limb must be functioning. And also the last one would be there is definitely no neurovascular involvement. And these are usually indicated in high-grade sarcoma with pre-op chemotherapy, or also known as the neoadjuvant chemotherapy, followed by the surgical resection and ended with a post-op chemotherapy, also known as the adjuvant chemotherapy. As you can see here, that the higher the necrosis rate, then the better the prognosis sign. Last treatment option should be amputation, because amputation is devastating and most centers nowadays would prefer to do limb salvage whenever possible. So most times amputation is chosen if there is a pathological fracture, because as we know, as long as there is a fracture or discontinuity of the bone, the tumor cells that is within the bone shall escape to the surrounding compartments, contaminate them, and making it an extra compartmental tumor, and therefore it is no longer a good candidate for a limb salvage resection. Next would be neurovascular bundle involvement, and also if during the pre-op chemo, the chemo is usually not working, the tumor is not responding to the drugs, and therefore the tumor enlarges. If you see any of these indications, then definitely amputation is the go-to choice. Next would be the post-management program, which shows us how much the prognosis is. We could see that the prognosis for patients with classic osteosarcoma, usually when they come to us, 10 to 20% is already present with pulmonary metastasis, and usually these populations of patients have around 70% long-term survival rate. This has increased from the past research because there are already effective regimens of chemotherapy which helps increase the rate of survival. However, some subtypes of patients still has a poor prognostic factors, which includes advanced stage chemo response, high alkali phosphatase, high lactate dehydrogenase, or any signs of vascular involvement. Well, I guess that is all for today's discussion regarding the intramedullary osteosarcoma. There will be next videos which discuss the other subtypes, which is the periosteal, paraosteal osteosarcoma, and also teleangiectatic type of osteosarcoma. Be sure to check out these videos at the second and third part of this osteosarcoma series. Thank you and subscribe to this channel for more videos.